Good morning. Welcome to the Florida Health Grand Rounds. I'm Etta Rodriguez, and I'm excited to welcome Dr. Thomas today. A few things to know before we get started. All phone lines are muted. Please enter in any questions you have to the question box. I will monitor that throughout the presentation, and all questions will be answered at the end. Today's presentation, I'm pleased to say, does qualify for continuing education. To get those, simply complete the survey that will be pop up at the end of the presentation, or the survey that's sent to you in the follow-up email. There is no need to complete both. If for some reason you don't get that follow-up survey or it doesn't pop up, go ahead and email me directly, ettarodriguez@floridahealth.gov. I'll go ahead and chat out that email as well. And then just a brief introduction before Dr. Thomas gets started. He is an expert in hepatitis B and C and hepatocellular sarcoma. Dr. Thomas has an active viral hepatitis screening program and is developing advanced models to study hepatocarcinogenics. As a South Florida native, he is committed to improving the treatment of viral illnesses and associated cancers in South Floridians. Please join me in welcoming Dr. Thomas.
So, thank you very much, Etta, for that kind introduction. And let me just say I'm very honored to give this talk. I have a funding from the Florida Department of Health from the Bankhead-Coley Cancer Research Program, and I'm very appreciative of the funding. It's really allowing us to do some work that I'm pretty excited about, and I'll present some of that data today. So I'm going to be speaking about strategies to eliminate hepatitis C and identify patients most at risk of developing HCC in Florida, and by HCC I mean hepatocellular carcinoma. So learning objectives today are to understand epidemiology of the Hep C with changes from the current opioid epidemic, to understand the care cascade involving both screening and treatment for HCV, and to understand liver disease progression and risk of developing hepatocellular carcinoma or liver cancer from hepatitis C. So I always like to start on the correlation between hepatitis C and liver cancer because it's something that's been developing over many decades. We first knew from a landmark publication from Harvey Alter, published in PNAS, that liver cancer was going to be increasing in the U.S. because of the hepatitis C infected population in the U.S. When they compared the U.S. population to Japan, they saw that the U.S. population was 30 years younger on average in terms of its hepatitis C population versus Japan. And at the time, Japan was having a huge incidence of HCC liver cancer. So they modeled that as the patients, these baby boomers, grew older with hepatitis C infection, that they would basically develop liver cancer as time went on. And this paper that was published almost 20 years ago is now coming to fruition, where we're seeing a consistent and significant rise in the incidence of hepatocellular carcinoma. Here's just another slide here just showing you that liver cancer is one of the few cancers that is increasing in risk, whereas most other cancers are actually decreasing in incidence. And so then the question is, why is HCC, hepatocellular carcinoma incidence rising? Well, it's really the increasing prevalence of patients with cirrhosis, or that end-stage liver disease, or F4 fibrosis. And we have a rising incidence of cirrhosis, mainly in the U.S. because of hepatitis C infection. Now, hepatitis B can also contribute to cirrhosis and liver cancer, and so can NAFLD, fatty liver disease. But in the U.S., currently, Hep C is still the main driver of liver cancer. And we also have improved survival of patients with cirrhosis. So the patients with advanced liver disease are living longer now. And because they're living longer, they have more time to develop liver cancer. So in the U.S., there's about 630,000 patients with cirrhosis. And unfortunately, many of the patients with cirrhosis are unaware of the diagnosis. And as I've mentioned to you about liver cancer, cirrhosis is also increasing in incidence. And cirrhosis, we know, increases with age. A lot of the risk predictors for predicting who has cirrhosis, age is a significant component of those prediction models. So we know that as you increase in age, you're more likely to develop liver disease. And unfortunately, there's no approved therapy for cirrhosis or liver fibrosis. And actually, there's no antifibrotic agent approved for any organ. So that is even for lung fibrosis or kidney fibrosis. So this is really an area of need. So how exactly does hepatitis C cause liver cirrhosis and liver cancer? Well, when a patient gets exposed to hepatitis C, they come down with an acute infection, and that acute infection can be subclinical, meaning the patient doesn't know that they're infected, or they can actually have symptoms of an acute infection. Some of those patients can actually spontaneously recover from the infection, meaning that they can actually cure themselves of hepatitis C. Unfortunately, about 70% of patients that get exposed to hepatitis C come down with what we call chronic infection, and that's infection for more than 6 months of hepatitis C. Once you pass 6 months of hepatitis C, you come down with chronic infection. And what we know is that over many years and decades of being infected with chronic hepatitis C, the inability of the immune system to clear out infected hepatocytes leads to fibrosis and scarring of the liver, and end-stage scarring is cirrhosis. These are pictures that I took from the transplant OR suite. This is the new liver that's going to be transplanted into a patient. You can see that it's smooth and functional. This is the cirrhotic, nodular, scarred, non-functional liver that was taken out as an explant. And this is what hepatitis C does over many decades to the liver. Now, this cirrhotic liver is a breeding ground for the development of abnormal cells that can become oncogenic or carcinogenic. And this is the environment that hepatocellular carcinoma develops. And this is why HCC develops a lot of the times in patients with cirrhosis. So cirrhosis is probably the biggest predictor of the patient's risk for developing liver cancer. Now, at the University of Miami, through our program, we have several endeavors to really try to limit this disease progression from infection to cirrhosis. And part of that is just by screening patients and detecting them early. We know that if we can find patients early before they develop liver disease and cure them, we know that we can stop this disease progression. So what's the current state of the HCV epidemic? Well, this is a quote from Scott Holmberg. Annual HCV-associated deaths in the U.S. have surpassed the total number of deaths linked to the other 60 nationally notifiable infectious diseases combined. What's more, these numbers are most likely an underestimate, since most patients that die of liver disease actually have it listed on their death certificate, and mortality from HCV continues to rise. So we have to acknowledge that HCV is a deadly disease. It just doesn't do it right away. It does it in decades, and with the aging population, this is becoming a significant problem for the United States. So now, how have things changed with the opioid epidemic? And before I start talking about the opioid epidemic, I just want to mention that I gave a talk last week at Robert Gallo's meeting in Maryland, speaking about the opioid epidemic. Actually, I gave a talk on injection drug use, HIV, and viral hepatitis in Florida, challenges and opportunities. It was a big honor for me to give the talk. Robert Gallo was there. He was organizing the meeting. But also, you can see the great list of speakers: Anthony Fauci, Dr. Giroir, Dr. Diefenbach, a really great group of speakers talking about the AIDS epidemic and its intersection with the opioid epidemic. And I'll present a lot of the information from my talk there. So in Florida, the opioid epidemic, has been a real issue. Drug overdoses more than doubled from 2014 to 2016, with about almost 5,000 deaths in 2016. Florida declared an opioid abuse of public health emergency in 2017, with approximately $27 million in federal funds for drug treatment and prevention. Florida also recently legalized syringe services program through the Infectious Disease Elimination Program, but unfortunately they prohibited the use of federal, state, or local funding for any syringe services site. So we still have challenges in the state that have hampered progress in addressing the opioid epidemic and transmission of the communicable diseases. These include no funding for syringe services programs, and also there's a clear increase in HCV transmission, and I'll present that data now. So as you can see from this data that's presented from the AMFAR website, Opioid deaths in the U.S. have been on a steady increase since 2012. And you can see Florida here in the blue has seen an increase that's almost greater than what we've seen in the United States. And the same pattern is seen for acute hepatitis C cases. You can see that in the blue that now we've had, over the past few years, a significant jump in the cases of acute hepatitis C, and now we've surpassed the average for the United States. Now, for HIV, you can clearly see that things seem to be somewhat stable in Florida, and we really hope that we can drive this decrease in HIV diagnoses down. But clearly for HIV, we're still in a phase of an increase in acute cases. This is something that I wanted to point out to you. Now, we've been testing for Hep C for several years now in Miami. This is a paper that we published in 2017. It's a very simple study. We just asked patients at a local STD clinic whether they had been previously tested for hepatitis C before and also for HIV before. And you can clearly see at this STD clinic that many more of the patients had been previously tested for HIV and not for hepatitis C. So what that tells us is that we really need to increase our screening for hepatitis C. Now, for HIV, we probably also need to increase screening for HIV also. As you saw from the previous slide, there still is a stable or maybe even increasing incidence of HIV in Florida. So I think both of these need to be increased, but Hep C needs to be increased much more, given the fact that it's much more prevalent than HIV. So this is data from mappinghepc.com, and what you can see is that among the states, Florida has some of the highest incidences of hepatitis C. This is data from 2016. And what you can clearly see is Florida is among the states that have the highest incidence of Hep C infected patients that are RNA positive. Now, we wanted to see what was the data for patients in Florida for actually getting treated. And you can see from the same website, mappinghepc.com, in 2016, there appears to be almost 10,000 patients that were treated for hepatitis C. So this is a good number. It's something that we can really be proud of. That there were about 10,000 people treated in Florida. Now, I think this number is a pretty high number. It was still around the time Hep C patients were warehoused. So there was a backlog of Hep C infected patients that were actually waiting to be treated. The numbers are probably a little bit lower now, but still there's thousands of patients that are being cured of hepatitis C. Currently in Florida, it's estimated there's about 150,000 patients. Now, if you compare us to other states, Louisiana has just started a very exciting program where they have a goal of treating 10,000 Medicaid enrolled patients and incarcerated by the end of 2020. So this is a kind of an ambitious program for Louisiana. They have about 40,000 infected Hep C patients, 30 to 40,000. So they're going to cure a big chunk. So that's about the same level that has been treated in 2016. So Florida's been, has had a history of reaching those levels of treatment. But considering that we have possibly 150,000 infected or more, we need to increase this number. And one point I wanted to make was that we are successfully treating Hep C patients and curing them in Florida. But for many of you from the HIV community that are aware of the concept of treatment as prevention, I think it's clear that for hepatitis C, treatment as prevention for Hep C in Florida does not appear to be working. And this is data, again, just showing you that Hep C is increasing in Florida, even though we're treating thousands of patients. So we really need to avoid complacency with hepatitis C. We do have fantastic drugs for this disease, but we really need to make sure we are working toward increasing treatment and getting more patients cured. So we want to avoid complacency. The other issue about Hep C is that when patients are cured, they can get reinfected. So that's an issue. And also, there's not a 100% cure rate with these new drugs. There are very high cure rates, but it's not 100%. And in Florida, we have some treatment-specific barriers that I'll speak about later, which is specifically the need for a specialist to be affiliated with treatment. And also, there still is testing for drug usage that can limit some patients from getting treatment. So to me, we can't treat our way out of this Hep C epidemic that's currently going on, and we need the increase of syringe services programs and programs that offer medication-assisted therapy for drug abuse to help decrease this increase in Hep C incidence. And this is just more data just to show you that Hep C is increasing in the U.S., but interestingly, it's happening in a younger population, and this is another effect of the opioid epidemic, where a lot of young people are using intravenous drugs, and because of that, they're acquiring Hep C, and this is a younger population. So it's a changing demographic of patients infected with Hep C. In the 70s, during the hippie era, those patients are all the baby boomers now, but we're seeing this new rise in young patients that are infected. Now, I also wanted to point out that, we do have a Hep C epidemic increasing, but this is in the setting also of hepatitis A increasing in Florida, and the Surgeon General just recently issued a public health emergency about the hepatitis A outbreak. And this is a big problem. You can see the huge increase in Florida from hepatitis A. And I wrote here, it's a drain on limited resources. We have a great viral hepatitis program at the Department of Health, but before they were dealing with hepatitis C and hepatitis B, now they're dealing a lot with hepatitis A and trying to get vaccination strike teams out in the community to really stop this epidemic of hepatitis A. This is something that's completely preventable, but unfortunately, the Department of Health in Florida is dealing with this, and that inhibits them from dealing with the Hep C epidemic that's also ongoing. So we have a lot of challenges in Florida. So this is just an overall summary of data from the AMFAR website, showing you the number of people that are living with HIV, about a tenth of the population in the U.S. with HIV, hepatitis C, again, a significant number here of hepatitis C, and drug-related deaths in 2017. So clearly, the opioid epidemic is impacting Florida significantly, and you can see which states are actually having the most drug-related deaths. And this map here showing you the number of deaths in Florida is similar to both the number of HCV RNA positive patients. This is data from mappinghepc.com, again from 2016, and also the HIV incidence rate. So you can see that South Florida and other places are really the epicenter of this issue, although this is a problem for all of Florida, and we need to really develop a statewide program to really address this. I wanted to point out that we recently had our first Hep C virus elimination meeting in Orlando last month. We were very excited to have representatives from the Florida Department of Health, and Carolyn Wester from the CDC was present, and we had a nice discussion to really address how we can really achieve Hep C elimination in Florida. So the first meeting, I wanted to thank Dave Nelson from the University of Florida and Betsy Schenkman and their group for organizing the meeting. And I was able to give the HCV elimination talk. And I'm working with Dave Nelson and others that were at the meeting to really develop this Hep C elimination program. In addition, I wanted to point out that the University of Miami has had a significant commitment to dealing with this problem of both HIV and Hep C. And I wanted to point out Hansel Tooks, who's really been a champion for getting the syringe services program legalized in all of Florida. And, it's been a pleasure to work with him. I've been able to do the Hep C testing with him at the needle exchange. And, we have this great team that's not only addressing HIV and Hep C, but also liver cancer and disparities. And this was part of our Cancer Center application. The University of Miami just became NCI designated, and some of our work was included in that grant and helped us get that significant NCI funding. So, clearly it's not just, the Infectious Disease Institute and AID that's supporting this work. now we have funding from NCI to address both HIV and Hep C in South Florida. So I just wanted to talk a bit about the Syrian Services programs. As we all know, Hansel Tooks is running the first program in Miami, and right now, if you go to the NASN website, right now there's 3 different Syrian exchange programs. IDEA is here, but there's also Flashlight, and then there's also Rebel Recovery in West Palm. And I just want to point out that we need many more than 3 Syrian Services programs in Florida. In addition, since there's not a lot of funding available for these sites, really the IDEA Exchange is the only site that's really offering comprehensive services. And we hope to see these other 2 sites here develop so that they can offer comprehensive services, including hepatitis C testing. This is just data from the testing that I'm doing with Hansel at the IDEA Exchange in Miami. This is a recent publication from Hansel showing you that, prior to this work, they already had an established Hep C positive population, about 266, at his needle exchange. But importantly, new testing has identified new patients that are infected with hepatitis C. These are the most recent numbers from our testing site, 77 Hep C RNA positive, and we found 2 acute Hep C positive. These are patients that are antibody negative and RNA positive. So in all my years of screening, this is the first time I've ever seen acute Hep C. So it's very worrying for me that, I'm starting to see these patients in our screening program. There were 8 co-infected patients with both HIV and Hep C in this number of 112 that were recently tested at the needle exchange. So it's just, again, pointing out that there are new patients being infected with Hep C that were unknown previously. Now, we have recently partnered with Gilead and the FOCUS program to establish a new screening facility for HIV and Hep C at the University of Miami Emergency Department. The needle exchange has already been funded by the Gilead FOCUS program, but we're one of the newer sites, and we're really excited about having this program that I think is really going to have a strong impact in Florida. And also, the FOCUS program is really located in many of the counties that have been identified to really need to be targeted in ending the HIV epidemic. So not only is the federal government doing something about this and our Department of Health, but pharma companies like Gilead are really getting involved in really trying to end this HIV epidemic, and also Hep C. So you can clearly see here at the University of Miami, we have 2 Gilead focus programs, the IDEA Exchange, and now the University of Miami Emergency Department. So we're very excited about that. So this program is being funded at a level of about $300,000 per year. We hope to screen about 10,000 patients for HIV and Hep C in the coming year. And the grant support is helping us offer a complete screening infrastructure and linkage to care for the patients that we found. And we hope to have this funding for subsequent years. And we also hope to expand this to hepatitis B. And, lastly, we hope to get data from this project to facilitate future funding for additional local projects and state projects for HIV and hepatitis C screening. So this is one of the things that we've done with our current Gilead award in the ED, where now our EPIC EHR has been updated so that HIV and Hep C tests are automatically ordered on the patients by the nurses. It's a nurse-driven program, and it doesn't need a physician to sign off on it. So it's something that's very exciting for us, and we hope to have many of the patients in the ED screened through this program. It's an opt-out testing program, and it's one of several of the Gilead programs that are currently ongoing. Also, FOCUS is really testing a lot of people for HIV and Hep C in Florida, and we really have to commend them for contributing to this. That's really going to contribute to ending the HIV epidemic. Now, the HIV program is really moving forward with a lot of federal funding. So what about Hep C elimination in the United States? Well, the WHO recently released their guidelines for global elimination of hepatitis C by 2030. Now, this is not eradication. This is elimination, which is, has defined goals for decreasing new infections and decreasing deaths from hepatitis C. And unfortunately, we had the recent HCV elimination meeting that was held by the AASLD, the American Liver Society. And at the meeting, there was data that showed that the U.S. was predicted to achieve the WHO guidelines for hep C elimination after 2050. So we are well behind what the WHO would like us to achieve in the United States. And why is that? Well, we have this opioid epidemic that's giving us new HCV infections. Many countries don't have new HCV infections going on like we have in the U.S. We don't have an active HCV vaccine. That would be a big help. As I told you before, there's reinfection. Treatment is simple, but it's still 8 weeks, so that's not, as short as it can be, and we hope it gets shorter. Unfortunately, there's not an ideal point of care test for hep C infection. Patients have to be first antibody positive and then reflex to an RNA test. So we really don't have any test and treat programs for hepatitis C like we do for HIV. I also mentioned that there's less than 100% cure rates with the new HCV drugs, and the cost of medications are pretty high, over $10,000 to $20,000. So there's some real burdens in Florida to achieve HCV elimination. So this is the data from the presentation that was given at the AASLD meeting in February 2019. And you can see there are certain companies like Japan, Italy, Switzerland that are really on track to reach the WHO guidelines. And you can see the United States is here as one of the countries that is predicted to achieve the WHO guidelines after 2050, well behind what many other countries will achieve. So this is a big problem for us. What we've also been able to show at the University of Miami is that it's not too difficult to successfully treat hep C infected patients that are uninsured. So even though we know that there's a high cost for hep C medications, if you have the appropriate infrastructure and support from patient assistance programs, you can treat uninsured hep C infected patients just as good as insured patients. This is data that was done in conjunction with Patty Ayala at Jackson Hospital, where we saw similar outcomes for hep C treatment, whether or not you had insurance here in the black or if you were uninsured here in the gray. So we saw no statistical difference between insured and uninsured in terms of being able to achieve good outcomes and being cured from HCV treatment. And this is just a bigger slide. This was a pretty large cohort of 216 patients that started, but 190 that actually completed treatment. So, we're very excited about this study, really showing that in addition to screening and finding positives, that we can actually cure these patients and even be uninsured without too much difference from insured patients. So now that we've talked about hepatitis C and treatment, I wanted to focus on what is the benefit of treatment, and that's really to prevent cirrhosis. If patients aren't cured of hep C and have it for decades, they can develop cirrhosis. And as I mentioned before, there are many patients with cirrhosis in the U.S., and there's no approved therapy for cirrhosis, and that this is driving liver cancer. So I was privileged and lucky to achieve a Bankhead-Coley Department of Health grant, 5-year grant, about $2 million. It's a clinical cancer research award, and it was really to identify covariates for HCC development. So we have a South Florida cohort of patients with liver disease at risk to develop liver cancer or hepatocellular carcinoma. We're doing a few parts, a cross-sectional study of existing data to try to identify patients most at risk to develop liver cancer. And then another part of that is a prospective longitudinal study where we follow patients over 4 years and do a FibroScan scan every year. I'll talk about that. To really try to identify which patients are most at risk. And we hope that by doing the study, we'll be able to develop a risk prediction model for individuals in Florida to identify patients that are most at risk of developing hepatocellular carcinoma. So our grant leverages the FibroScan technology. It's a very simple and straightforward ultrasound-based device that can give us a really quick, non-invasive indication of how much fibrosis is in a patient's liver. Before we had the FibroScan, patients had to have a liver biopsy done to really accurately assess their stage of fibrosis. But now that we have this machine, the FibroScan, we can do this in a much easier way that's much less of a burden to patients. And this is not the only way that you can do liver fibrosis assessment through elastography. There are also other ultrasound-based methods. We have both of these at the University of Miami at the Schiff Liver Center, but our grant is mainly focused on utilizing the FibroScan. Now, what we published in 2015 is that we can use the FibroScan, and that's shown here, transient elastography, to really predict biopsy-proven fibrosis and cirrhosis. So we've published, and this was specifically done in obese patients, which are harder patients to do a FibroScan on, but we were able to publish in 2015 that this technology is really good for evaluating patients' fibrosis. So based on FibroScan, we have already developed an advanced model consisting of not just the FibroScan, but also albumin and platelets that give us a 0.94 area under the curve of detecting cirrhosis by biopsy. So we don't need to necessarily biopsy patients, but we can, using this algorithm, really have a good predictor of which patients are cirrhotic and most at risk of liver cancer. Now, the area under the curve is not as good for both patients with F3 and F4, that's significant fibrosis and cirrhosis, but the patients that we most want to find, the cirrhotics, we have a non-invasive way to really determine that. So one of the things we're doing in this grant, which we're excited about, which really hasn't been done yet, is we're stratifying our cohort by race and ethnicity. And we're finding some differences between races based on and their level of liver disease. So we hope to eventually develop a race-based risk calculator for liver cancer. And we think certain populations may be more at risk for developing liver cancer just because of their race. And so for us, this is an exciting scientific area to also be pursuing in addition to the clinical prediction model. There are other risk stratification models. This is one that we're using to validate our race-based prediction model. This one's called the THRI, or the Toronto HCC Risk Index, and it's actually pretty good about actually understanding which patients with cirrhosis are most at risk for developing liver cancer. So what we've recently shown is that FibroScan correlates with this HCC risk prediction model, meaning that patients that have a high risk for developing liver cancer based on THRI also have a high FibroScan score. And so adding FibroScan to existing risk prediction models for liver cancer, we think is going to be, it's going to help actually improve the performance of the prediction models. And then this is data here just showing you some of the many different clinical parameters that we're evaluating in our prediction model. And even now we're able to look at THRI, and we think that we can do better than THRI at risk prediction when we incorporate multiple other parameters, including FibroScan. You can see here in this data set for cirrhosis, the area under the curve for FibroScan is 0.877. But this is for fibrosis prediction. So it's something that we're excited about, and we wanted to extend that from fibrosis prediction, cirrhosis prediction, to liver cancer prediction. One of the other interesting and novel things I think we're doing is we're actually taking our FibroScan data and plotting it by zip code to try to identify areas that have a higher incidence of liver disease. And we think that this might help show areas that may have environmental contributors of liver disease and liver cancer. So you can see here, this is HCC incidence in Florida from 2011 to 2015, and you can see the incidence is really high in Key West and in some of the Central Florida areas. And that actually looks somewhat similar to the maps that we've shown here, both for FibroScan mapping. You can see the keys are always on the darker side. And we've actually also plotted THRI in our patient population. And again, you see higher risk scores in this area and also in the Keys. So it's something that we hope to also add to our prediction models, maybe even patient zip code and geo location to our risk models. So this is a specific map of hepatitis C infected patients based on THRI. The previous map was all of our patients with liver disease. This is looking at our hepatitis C specific map. So again, a lot of red, a lot of areas where patients may be at increased risk of developing liver cancer because they've been infected with hepatitis C. So it's something that we're kind of excited about looking more at. So in addition to the geospatial analysis, we're also adding genetic analysis and to really identify patients that are at risk. We think that there are going to be genetic parameters that really drive patients' risk for liver cancer. Recently, the TCGA, or the Cancer Genome Atlas, was published in Cell in 2017, really giving us a framework for the genetic mutations that can actually predispose someone to liver cancer. So we are actually utilizing some of this data in our Bankhead-Coley grant. The other thing I wanted to point out was that liver cancer, if you look at it from a proteomic and genomic standpoint, it's more diverse than most of the other cancers combined. So liver cancer is really unique in its genetic heterogeneity. It's probably because it arises from a lot of different etiologies: hepatitis C, hepatitis B, other forms of cirrhosis from alcohol. So it's one of the challenges about liver cancer is that it's a really genetically diverse disease when you compare it to other types of tumors. But we do still think that there's going to be genetic information that will help us find patients that are most at risk. Now, one of the consequences for liver cancer being such a diverse tumor genetically is that there are very few targeted therapies for liver cancer. And this is why this disease is so deadly, is that we really don't have good treatments once patients have advanced disease. And you can see for many of these other tumors, they actually have targeted therapy that will actually treat patients with specific mutations, and we really don't have that for hepatocellular carcinoma yet. Many polymorphisms have been implicated in the development of liver cancer, including those at the interferon lambda 3 IL-28B gene and those in the PNPLA3 gene. So these are the genes that we're actually assessing and studying in our cohort in Miami to see if that will help us stratify patients that are most at risk for liver disease, meaning that if they have the risk allele for interferon lambda 3/4 or PNPLA3 or MICA, that they may be more at risk of developing liver cancer because they have the risk allele. So I think it's something innovative that we're doing in our Bankhead-Coley grant. And so this is just a diagram of the actual in-house TACMAN probe assay that we use to actually genotype patients. This is a specific assay for RS1297980, which is a mutation at the interferon lambda 3 IL-28B locus. Now, one of the interesting things about this specific locus and polymorphism is that the risk allele is actually more prevalent in African Americans, meaning that if you're African American, you're more likely to have a mutation that predisposes you to having hepatitis C and subsequent fibrosis, and we published papers on that. So this is a disparity that is different than most disparities. Most disparities, people would argue, are from socioeconomic factors, but this disparity, specifically in hepatitis C and liver disease, is a genetic disparity that affects races differently, and it's something that we hope will help us in developing this race-specific risk prediction model in Florida. Now, I do have this grant at the University of Miami, but one of the things that we've been actively trying to do is expand our work to the rest of Florida, and I showed you our HCV elimination efforts. We've also submitted an infrastructure grant with the University of Florida, Moffitt Cancer Center, and Jacksonville Mayo Clinic to take the models that we've developed and see if we can apply it for the rest of Florida. And we're leveraging the One Florida database that's out of the University of Florida to try to see if we can use a non-invasive predictive model to identify patients in Florida that are cirrhotic, but they don't know it. And what we've been able to do is, since we can't do a FibroScan on everybody in the state, and many patients in the state haven't had a FibroScan done, we've developed an estimated FibroScan. So based on this model, we're able to get a 0.832 area under the curve for detecting cirrhosis, and we hope to expand that and test and screen the rest of Florida using the One Florida database to try to identify cirrhotics who don't know that they have cirrhosis. In addition to the work that I previously shown you incorporating genomics and clinical covariates of liver disease, we're also adding some other exciting technologies at the University of Miami to find patients most at risk and to also identify hepatocellular carcinoma earlier. These two technologies are circulating tumor cells, which are cells that you can find in the blood of patients that have early cancer, and also specific MRI and CT platforms to help us actually identify patients with smaller nodules that may have early liver cancer. And I've already mentioned the genomics. These circulating tumor cells are a really exciting area. At the University of Miami, we use a filter-based technology to actually capture these cells from patients' blood. And these are cells that we can subsequently study and analyze to see if they are actually from an early tumor. So it's another way that we can identify patients that may have small tumors. Here's a contrast-enhanced image showing you two patients that have a very similar nodule in their liver. But of these two patients, only one of the patients went on to develop liver cancer. So that's what we're trying to do at the University of Miami, is develop models where we can detect a real HCC earlier. Now, what I'll show you is that of the two patients, this patient actually went on from a small 30 millimeter HCC to a much bigger HCC, as you can see here. And this patient had a TIPS procedure done. You can see that in the image here, just to convince you that this was the patient whose tumor actually went on to liver cancer, and this patient's tumor did not go on to liver cancer. So it's something exciting that we're doing. We've published this data now at some international HCC meetings. This was at the EASL meeting in Portugal last November. So we hope to further develop this modality of identifying patients early with HCC. So yes, I have a question. 5 minutes, okay. So in addition to that, we're adding other clinical covariates to our model, including the CAP score that we can use from FibroScan. That's actually an assessment of steatosis in the liver, and we think that may also predict patients' predisposition to developing cirrhosis. We're also using a test from Siemens called the ELF fibrosis test that we think can also be used in the model. And then we have also additional biomarkers that have been used to actually detect liver cancer. And so we want to actually do this in our patients. And I've already mentioned race and ethnicity and other age-independent risk. We know that age is associated with development of liver disease and liver cancer, but some patients do develop it earlier and at a younger age. So we want to see if there are any specific predictors of the development of liver cancer at a young age. And lastly, some patients can develop liver cancer that are non-cirrhotic, and we want to develop models to try to identify which of those non-cirrhotic patients will get liver cancer. Now, this is more of a rare occurrence, but it still happens, and if we can develop a model in that population, that would also be great. I just want to point out that I'm hosting at the liver meeting coming up in November a workshop on HCC. It's actually going to be on Sunday of the liver meeting this year, and if any of you are at the liver meeting, please come to the HCC workshop. It's at Sunday morning from 8 to 12, where we'll be discussing the most new and innovative technologies and science around liver cancer. So I'm going to finish up here, and I wanted to finish up with the opportunities and challenges for Hep C screening. And some of these are specific to our ED screening program, but others are specific to the rest of Florida and the community. But bottom line is that we need to increase screening, testing, and diagnosis of hepatitis C according to CDC guidelines in both public and private healthcare settings. And as I told you before, with the increase in HCV incidence in younger populations, we need to make sure that we're being inclusive of younger at-risk populations. And actually, I saw yesterday from the Department of Health that there was a new notification about hepatitis C sent out that specifically mentioned testing younger at-risk populations. So I'm very excited and happy to see that. We also need to build capacity within our existing workforce to treat patients in diverse healthcare environments, including non-specialists. We need to move away from specialists for treating patients for Hep C that don't have advanced liver disease. There's a lot of those patients, and it's something that other states are able to do, is utilize non-specialists to actually treat hepatitis C infected patients that do not have liver disease. We also want to ensure that all hepatitis C patients have access to these new direct-acting antiviral agents, and we want to hopefully remove these usage restrictions on patients' access to HCV treatment. And specifically, maybe just removing the ethanol and marijuana restrictions may be a significant help to this population, although some providers do feel that this usage restriction isn't that big of a deal and they can get around it. And also, we want to pursue policies and legislations in alignment with the WHO and CDC guidelines that will help achieve elimination in Florida. And these include opt-out testing, testing of patients that have had an overdose, and actually helping emergency departments actually be reimbursed for screening for hepatitis C. As what I've heard is that emergency departments currently can't actually be reimbursed for any of the Hep C or HIV screening programs that they do. So again, I just want to ensure access for Hep C patients to these drugs, try to get ED reimbursement pushed forward for screening, and then again, really try to move Hep C opt-out testing legislation forward in Florida. Now that we have lower drug costs for Hep C treatment, and possibly that the treatment of prisoners is becoming less of an issue, hopefully we can let legislation to really support Hep C opt-out testing in Florida, and also legislation to treat unconscious patients that are presenting to the ED with a drug overdose. Currently, if a patient is unconscious and unable to consent for HIV or Hep C screening, an ED can't screen them. So we want to pass legislation that if a patient comes in unconscious from an overdose, this is a very high-risk population, that the actual ED can actually screen them. So with that, I'll end. I'll thank all of my colleagues that have collaborated on this work, and thanks again the Department of Health for their support of our funding, and also for everything that they do for HIV and viral hepatitis and other communicable diseases. And at this point, I'll take any questions. So thanks for your time.
Thank you for a wonderful presentation. We have several questions that have already come in. One is just if you could provide more information or just a reminder of that workshop you mentioned that you'll be presenting at in November. Yeah. Somebody was interested in hearing the name of that and where it's located again. So if you could just...
So that workshop is going to be at the AASLD, American Association for the Study of Liver Diseases meeting in Boston. The meeting is held from November 7th through the 11th. And the workshop is actually going to be on Sunday of the meeting, which I believe is November 10th. Can you check the calendar really quick? So again, that's the AASLD liver meeting held in Boston this year, and the HSC workshop is from 8 a.m. to noon on Sunday, November 10th at Boston. We have a national and international group of speakers that are really going to update the liver community on the most new and innovative technologies to study and actually also for early detection of liver cancer.
Our next question is, what impact do you expect the needle exchange programs, now that they're legal in Florida, to have on the rate of hepatitis C?
That's a great question. And first, let me say that, again, I want to congratulate Hansel Tooks for the great job and the rest of the representatives for really championing the legalization of syringe services programs. But honestly, one of the challenges is that there's lack of funding for the syringe services programs. So yes, we have one comprehensive site in Miami. We have a few coming online. But without funding, the impact of the legalization of syringe services programs is going to be minimized. There really needs to be support for these programs to really make them impactful. And, what I'll tell you from, testing with Hansel Tooks at the needle exchange, as I said, we found, 100 patients with new Hep C. Every new needle exchange program that's opened up are going to find new Hep C infections that aren't currently in the healthcare system. These persons who inject drugs are usually not actively engaged in healthcare. And they get healthcare at these syringe services programs, but they also get diagnosed for hepatitis C. So having more syringe services programs and having funding to support them will really allow us to find a lot of these hepatitis C infected patients that currently aren't diagnosed. I think in Florida, we probably need at least 10 to 20 of these. And with each new site that's opened, we'll probably find another 100. So I think there's thousands of Hep C patients that don't know that they're infected, and we really need the syringe services programs to help identify them.
Okay. Our next question is asking about, we already have a vaccine for hepatitis B and hepatitis A, so can you speak to whatever barriers or issues there might be surrounding the development of a hepatitis C vaccine?
This is a big issue. For us to achieve Hep C eradication, we're going to need a vaccine. Some modeling has shown that we can achieve elimination without a vaccine, but that's really going to depend on getting this opioid epidemic under control. So why is it hard to get an HCV vaccine? Hepatitis C is an RNA virus that's incredibly polymorphic. It mutates and changes and evolves so that it can evade our immune system and our ability to develop really good antibodies against it. And this is very similar to the situation that's there for HIV. We also don't have an HIV vaccine. Now, there are some exciting developments in HIV vaccine research, but what I'll tell you is that it's going to be harder to develop a hepatitis C vaccine than an HIV vaccine because the virus is so much more polymorphic, meaning hepatitis C is so much more polymorphic than HIV. However, we do have a cure for Hep C, so that is some good news. But we're hoping to learn from the HIV group. We hope that they will have an HIV vaccine within 5 to 10 years, and then shortly after that, we'll have a Hep C vaccine. But clearly, the issue is that these viruses mutate and change to evade the antibody response that our bodies propose. And this is why you can get reinfected with HCV. You get cured, but you still don't have good antibodies to stop you from getting reinfected. And, I've seen studies from Europe saying that there can be as high as a 13% reinfection rate in drug users. So it's a problem.
Our next question is, what about the use of a serum fibrosure test?
So there are many non-invasive ways to assess liver fibrosis. Fibrosure is one that's currently a clinician can order, but there is a cost to it, and for uninsured patients, I'm not sure how practical it is to get a fibrosure. If they have Medicaid and other areas of support, they probably can get a fibrosure, but it's good and it's being utilized. The FibroScan, we think, is something that can also be done. Again, there are limits to how many FibroScans can be done. So I think you are right. Ultimately, multiple modes of fibrosis assessment will need to be done if we're really going to impact this increase in HCC incidence. And fibrosure is definitely one of the platforms that can be utilized to help identify cirrhotics.
Okay. So our next two questions are about, why is HCV more prevalent among African Americans, and are there any differences in terms of gender or age?
Okay, so I didn't have the race-based data for hepatitis C in the United States. and in Florida. The data that I did show you was based on a risk allele in the IL-28B interferon lambda locus. Now, African Americans have a mutation in this allele that makes them more predisposed to having chronic HCV infection, meaning they're less likely to cure the virus on their own. Now, in the U.S., if you look at hepatitis C, I still think white Caucasians have the highest incidence. But if you look at which populations are having the most increase in new HCV infections, it's moved from whites, which were infected in Caucasians, which were infected in the 70s during the hippie era, to other races. And liver cancer, which is also very predominant in whites, is also becoming increasing in other ethnic races, including Hispanic and African Americans. So as far as Florida data, I don't know the race-based breakdown of it, but it's one of the areas that's increasing due to the opioid epidemic. But overall in the U.S., I think the Caucasian population has the highest burden of hepatitis C.
Okay. This next question is in regards to a hospital. They say they have many co-infections of Hep A and Hep C. Is there a reasonable explanation for this?
You know, I think that's fascinating. I haven't seen that data, and it really comes down to what is the explanation for the recent hepatitis A outbreak. When I talk to Gene Schiff and other leaders in the field, they think it's an increase in homelessness, and that this population that are homeless are spreading hepatitis A. Then the question is, why are they becoming homeless? And one hypothesis is that the opioid epidemic is resulting in more individuals that are unable to, have a stable lifestyle, and it's pushing them on the streets. And then when you push this population on the streets that have a high Hep C, they're now on the streets, now they're transmitting hepatitis A. That's just a theory, but to me it's something that needs a lot more research. And I would like to see the data that there's co-infection of both hepatitis C and HAV in this population, hepatitis A, because I haven't seen that data. But that would be something that may show that the opioid epidemic is tying in with this Hep A epidemic and through homelessness.
Okay. And the last question we have time for is, currently do Florida public health clinics practice the opt-out to STD HIV testing in their registration process?
So I went to the state legislature in 2014 to support a hepatitis C opt-out testing. That bill was supported by the AIDS Institute and Mike Rapal there, and it didn't pass, mainly due to fiscal concerns with having to treat all the hepatitis C infected patients in prison. At this time, Hep C opt-out testing is not legal in Florida. We hope to reintroduce that bill this year and make it legal. Now, the focus programs supported by Gilead are really promoting Hep C opt-out testing model. So what have we had to do in the emergency department to get this done? We have to change policy in the hospital to get the hospital behind opt-out testing. So Hep C opt-out testing, from my understanding, is only being done at specific sites that have changed policies to allow that and have had other administrative procedures done to allow Hep C opt-out testing. So from my understanding, it's definitely not something that's occurring throughout the state of Florida.
Thank you so much, Dr. Thomas, for a wonderful presentation. Just a few reminders. This presentation does count for continuing education credits for nurses. To get those credits, you must complete the survey that pops up at the end of this presentation or the one that is sent out in the email. There is no need to do both. If for whatever reason you don't get access to either of those surveys, please email me directly, Etta Rodriguez. And even if you just want a certificate of attendance, you must complete that survey. Even if you don't want continuing education credits, but you want the certificate of attendance. Additionally, our next presentation will be on November 12th at 10 a.m., and we will be featuring Dr. David Lowenstein of the University of Miami. Dr. Lowenstein will be presenting on novel cognitive stress test paradigms, biomarkers, and detection of early Alzheimer's disease. November is National Alzheimer's Awareness Month. You can register by following the link that will be sent out later this month. And a special thank you to Dr. Thomas for joining us today, and thank you for everybody that listened. Have a great day.